dear participants. My name is Mariangela Pellegrini. I'm the Educational and Patient Program Manager for the EHA ERN-EuroBloodNet. And it's my great pleasure to welcome you on behalf of the European Hematology Association and the EHA ERN-EuroBloodNet to the third webinar of the program named EHA and ERN-EuroBloodNet Spotlight on Castleman Disease. That is an accredited European online educational program targeting health professionals, co-organized by the EHA and the ERN-EuroBloodNet. As you may know, this program consists of 4 sessions, of course, focus on Castleman disease, and it is an accredited program by 4 continuing medical education points submitted by the European Board for Accreditation in Hematology. So each session is 1 credit, so you can get both full credit for the full program or require only 1 credit associated to the lecture you have assisted. How to get those points? Basically 2 rules, so please pay attention that you have insert your full name and surname in the Zoom platform, and also at the end of the session you are going to receive a survey with 3 basic questions, but it's mandatory to answer in order to get the accreditation because we will need to track your presence. Some more house rule before starting, sorry for that. So as you may notice, this session is recorded because it will be implemented in the both EHA and EuroBloodNet e-learning environment. So if you don't feel at your ease, please put your camera off, and also being kindly informed that your microphone will be muted along all the presentation. We are going to assist, but if you have any question, you can both write them in the chat, or at the end of the presentation, you can take the floor and address the question or comment feedback orally. But we can finally arrive at the point of today's lecture. So today is the 3rd session of this comprehensive program. We are going to talk about idiopathic multicentric Castleman disease. The lecture is provided by Dr. Simone Ferrero, who is Assistant Professor in Hematology, Division of Hematology, the Department of Molecular Biotechnology and Health Science at University of Torino in Italy. And it's my great pleasure to welcome the speaker today. So please, Dr. Ferrero, the floor is yours. Thank you.
Hello, good afternoon, everybody. Talking about idiopathic multicentric Castleman disease. I'm working with Castleman since 5 or 6 years. I work in collaboration with the Castleman Disease Collaborative Network, and I have also the honor to be the Vice President of the Italian Association of Castleman Disease Patients, who was founded here in Torino 6 months ago. So today we'll talk about the idiopathic form of multicentric Castleman disease. Here are my disclosures. And here are the learning objectives of the webinar. So the main discussion points today will be the clinical phenotype of the disease, then the differential, the problem of the differential diagnosis, in particular with the relationship with the TAFRO syndrome, with the IgG4 related disease, and POEMS syndrome. Then we talk about the pathophysiology of idiopathic IMCD, and finally some issues about the treatment. To start with the clinical phenotype of the disease, I will present you a clinical case, a patient of mine, 50 years old Caucasian male. He was admitted for a fever of unknown origin, persisting for 1 month, associated with nocturnal diaphoresis, asthenia, and chills. Laboratory results demonstrated a mild anemia, normal platelets, leukocytosis with neutrophilia and monocytosis, with inflammation, with elevated inflammation markers, I mean CRP and ESR. He presented with a slight hypoalbuminia, while blood culture and serological tests excluded infections. A CT PET scan was performed, demonstrating small adenopathies, abdominal small adenopathies, peripancreatic and retrocaval, with a maximum size of 23 millimeters. But PET was positive with a maximum SOV of 12.7. We first performed a bone marrow biopsy, as the adenopathies were very difficult to get a biopsy. But bone marrow biopsy showed only a reactive phase, so with granulomas and excess of interstitial and perivascular polyclonal plasma cells. So we performed a surgical lymph node biopsy of the adenopathies, and the histological report showed vascular plasma cells proliferation and expansion, along with focal aspects of follicular regression. So overall, the histological report was compatible with an HHV8 HIV negative idiopathic multicentric Castleman disease of uncertain histopathological classification. So what is IMCD and what is his epidemiology? There are no many data, no clear data about epidemiology of this rare disease. But recently, a paper has been published in Blood Advances with some interesting epidemiological data from 11 states of the United States. The epidemiology may be clearer thanks to the advent of a Castleman disease specific ICD-10 code. We can estimate from these data, that are the only published data, an incidence of IMCD in the United States of 3.4 cases per million. So it's a rare disease, and a prevalence of about 7 cases per million. What is the clinical presentation of IMCD? Typical clinical presentation is lymphadenopathy, with the presence of B symptoms. It can be present hepatomegaly or splenomegaly. There could be pleural effusions, anasarca or ascites, while severe IMCD cases show an important generalized inflammation status with organ failure. Sometimes it can be present skin involvement, so cherry hemangioma. Regarding laboratory abnormalities, we can have elevation of classical inflammatory indices, in particular ESR and PCR and CRP, hypoalbuminia, hypergammaglobulinemia. Sometimes it could be proteinuria and renal impairment. From a hematological point of view, anemia, thrombocytosis, or on the contrary, on the other side, also thrombocytopenia. And sometimes some autoantibodies like antierythrocytes or antiplatelets can be detected. Here is the recommended workup from the Castleman Disease Collaborative Network of IMCD. You can see inflammatory response indexes, histopathology, of course. We should always investigate virological status, particularly to rule out HIV and HHV8, but also other viruses. Cytokine profile could be useful, but is not essential for diagnosis. For example, interleukin-6 dosage. Very important is imaging, CT and PET-CT. It is important to do a bone marrow evaluation to rule out other conditions. Final, some rheumatoid screening, and then organ function to evaluate cardiac function and pulmonary function. This is the typical histological presentation of IMCD. Probably you've already heard about this in another webinar, in a previous webinar. But there are three types of histological presentation: the hypervascular type of IMCD, and on the other side, the plasmacytic subtype. But sometimes the histology can be mixed. What about differential diagnosis? It is very important to make a clear diagnosis of IMCD that is not made only on the histological report, because here are, you can see the diagnostic criteria of IMCD published by in 2017 on blood by the Castleman Disease Collaborative Network. To diagnose IMCD, you should have both the major criteria that are enlarged lymph nodes, at least 1 centimeter, in at least 2 lymph node stations, that is multicentric, and an histopathological report compatible, consistent with the IMCD spectrum. But besides the major criteria, we should have at least two minor criteria, of which at least one laboratory criteria, like, for example, inflammatory indices. Then, if we have at least two, the major criteria, and at least two minor criteria, we should exclude other associated conditions that can mimic idiopathic multicentric Castleman disease. And these are, first of all, infection-related disorders, like, for example, an EBV infection. Autoimmune or autoinflammatory diseases, rheumatologic, like Steele disease, for example. And finally, malignant or especially lymphoproliferative disorders or plasmacytic disorders that, for example, can be associated with POEMs. Then we can grade the severity of IMCD. To define a severe case of IMCD, we should have at least 2 of these 5 established criteria. So worse cycle performance status, at least 2, stage 4 renal dysfunction, the presence of anasarca or ascites, or pleural pericardial effusions, an anemia with hemoglobin less than 8, or a pulmonary involvement that is typical with interstitial pneumonitis. This is another clinical case of mine, just to be certain of the diagnosis. The title is IMCD or not IMCD. She is a young girl, 34 years old, with bilateral axillary adenopathies. At the CT scan, maximum 2.8 centimeters, without any systemic symptoms. These adenopathies were biopsied, and the histological report was consistent with follicular lymphoid hyperplasia, with regression of germinal centers, and so was compatible with the diagnosis of IHV-8 negative, HIV-negative Castleman disease. However, blood tests were all normal, no viral infection, no renal impairment, normal interleukin-6 levels. So, as you can see on the right, this girl has the 2 major criteria, but no minor criteria. And so, diagnosis of IMCD in this case was not possible. What about the relationship with other peculiar conditions that can be associated with Castleman disease or can go in differential diagnosis? First of all, we have to remind that patients with IMCD have a prevalence of neoplasm in general 3 times higher than healthy controls. And the relationship between IMCD and neoplasm remains unclear. Then there is a peculiar type of syndrome associated with Castleman, that is a TAFRO syndrome, that may be associated with Castleman or may also not be associated with Castleman, but with something else. Then we will talk about IgG4 related disease that is frequently seen in patients with Castleman, but is not a criteria of exclusion. And then the POEMS syndrome, that is often associated with Castleman disease, but it is a different disease and is considered the result of a cytokine storm. So here is a clinical case of TAFRO syndrome, 57-year-old male who was hospitalized for abdominal pain, vomit, fever, dyspnea, and declivus edemas, so worse general conditions. His blood test demonstrated leukocytosis and thrombocytopenia, 60,000 platelets, abnormal coagulation tests, elevation of creatinine, so initial renal failure, elevation of alkaline phosphatase and gamma-glutamyl-transferase, and elevated CRP, 200. Moreover, hypalbuminemia, and at the same time, blood cultures were negative. A CT scan demonstrated a perihepatic effusion, splenomegaly, 16 centimeters, a mild increase of size in abdominal lymph nodes, but mediastinal adenopathies, maximum 2.4 centimeters with bilateral pleural effusions. Then the patients rapidly worsened with anuria, so we started dialysis, hypotension, so it was admitted in the emergency. We use infusion, vasoconstrictors, CPAP for respiratory failure, and fever, but extended spectrum antibiotics and antimycotic drugs were not effective. Finally, we performed a bone marrow biopsy that shows reticulum fibrosis and megakaryocytic line expansion. So what is this? This is a TAFRO syndrome. T for thrombocytopenia, A for ascites, F for reticulum fibrosis or fever, R for renal dysfunction, and O for organomegaly. So TAFRO syndrome, as I said, can be associated with idiopathic multicentric Castleman disease, demonstrated by surgical biopsy, or can be associated with a Castleman disease not demonstrated with a surgical biopsy, for example, as in this case, as the general condition of patients did not allow a surgical biopsy. Or in some other cases, TAFRO syndrome can also be associated with other comorbidities and without Castleman disease. For example, TAFRO can be observed in cases of malignancies or of infection diseases or in rheumatological disorders. Typically, TAFRO syndrome, when associated with Castleman disease, is associated with an hyaline vascular or mixed form. What about IgG4 related disease? This is a rare fibroinflammatory disease characterized by tumefactive inflammatory infiltrates in fibrosis of glandular tissues. Classical presentation of IgG4 related disease is can be with autoimmune pancreatitis, retroorbital disease, pseudotumor, or a major salivary gland involved. Sometimes there could be a Castleman disease-like morphologic subtype. So the histological report may suggest multicentric Castleman disease. It is characterized, the histological report, by abundant mature IgG4 positive plasma cells in interfollicular areas. So the diagnostic criteria of Castleman disease that I presented before are very useful to differentiate Castleman idiopathic from IgG4 related disease. Finally, POEMS syndrome. What is POEMS? Is a paraneoplastic syndrome, typically occurring in the presence of a monoclonal immunoglobulin spike, and is characterized differently from Castleman by polyneuropathy, organomegaly, that can be similar to Castleman, endocrinopathy, that is not typical of Castleman, for sure, monoclonal immunoglobulin spike, that is not typical of Castleman, and skin changes that are different from the cherry hemangiomas of Castleman. It is important to remind that multicentric Castleman disease can co-occur with POEMs, and in particular, the histological proven Castleman disease is a major criterion in the diagnosis of POEM syndrome. However, we should remind again the IMCD diagnostic criteria to differentiate these two conditions, because as POEM syndrome requires both polyneuropathy and monoclonal plasma cell proliferative disorder. This is one of the reasons why it is important to perform a bone marrow biopsy in the differential diagnosis of Castleman disease. This is another clinical case of mine, POEM syndrome versus IMCD, 72 years old male. He was hospitalized for suspected lymphoproliferative disorders. PET and CT scans already 5 years ago demonstrated multiple lateral cervical, axillary, and mediastinal lymphadenopathies, maximum size 3 centimeters. They were PET positive with a submax of 11.6. And lymph node biopsy performed in 2017, demonstrating a Castleman disease with hyaline vascular variant. So it was diagnosed as, was incorrectly diagnosed with IMCD. And we were able only 2 years after to suspect POEMs, while he had evidence of lower limbs neuropathic pain. In blood test, it was found a serum monoclonal protein, IgG kappa. Both IgG kappa and IgG lambda, HIV and HHV8 were negative. An electroneurography showed a sensory and motor polyneuropathy, negative for anti-MAC antibodies. And so, if we remind the IMCD diagnostic criteria, these were only the major criteria were fulfilled, again, so the histological and the presence of lymphadenopathies, but no minor criteria are fulfilled. Moreover, there is a serum monoclonal protein and polyneuropathy. So, in only the last year, in 2021, we made a diagnosis of POEM syndrome that was confirmed also by the dosage of VEGF that was abnormal. It is one of the minor criteria for the diagnosis of POEMs. So patients were treated with say 6 cycles of lenalidomide plus dexamethasone and obtained a very good clinical response. And so he did not receive therapy against Castleman disease because it was a POEMs. Finally, what about pathophysiology? The importance, the central role of interleukin-6 as a mediator of inflammation in Castleman disease has been described more than 30 years ago. This report of 1989 described 2 patients with Castleman disease. Both patients showed elevated interleukin-6 levels compared with controls. After resecting the enlarged lymph node of the first patient, all the abnormal findings disappeared, and also a marked reduction in serum interleukin levels was registered. On the other hand, in the patients 2, after a surgical biopsy, symptoms and elevated interleukin-6 levels persisted after surgical removal of the enlarged lymph node. So, why interleukin-6? Because Castleman disease is characterized by a cytokine and chemokine storm, so with a generalized inflammatory disease, mainly mediated by interleukin-6. This is the common pathway that can have different etiopathogenetic hypotheses. Which are the most studied hypotheses? First of all, the autoimmune or autoinflammatory hypothesis. So there could be autoantibodies triggering pro-inflammatory cytokine release by antigen-presenting cells. or can be a dysregulated signaling in an APC, or finally a defect in the regulation of activate inflammatory cells. But these are only hypotheses, as no autoantibody or was recognized so far, has been recognized so far. Another hypothesis contemplate a paraneoplastic hypothesis. So the paraneoplastic inflammatory syndrome may be due to a somatic mutation in a benign or a malignant cell that could be inside or outside the lymph nodes. Some preliminary data suggested that may be lymph node stromal cells, but again, no demonstration. We have no demonstration of a tumoral cell causing IMCD. And finally, the pathogen hypothesis. It is possible that this inflammation involves either an infection with an HHV8 clinically undetectable, that is typical of HHV8 Castleman disease, or it could be due to a novel virus or another pathogen that we are still not able to identify. But as you can see in the graph on the right, all these hypotheses have a common pathway that involving interleukin-6. And so what could be the treatment for IMCD? These are the published guidelines from the Castleman Disease Collaborative Network, published in Blood in 2018. As you can see, first of all, you should differentiate, you should identify a severe form of Castleman disease versus a non-severe form. But the first-line treatment, the recommended first-line treatment is an inhibition of interleukin-6 that can be done either with siltaximab or with tocilizumab, or with a 2B category evidence. With a lower evidence, the treatment can be done with rituximab. But why interleukin-6 blockade? You can see here that there are two ways of blocking interleukin-6. You can inhibit directly the protein, the interleukin-6, with the direct antibody, that is siltaximab. Or you can block the interleukin-6 binding to the interleukin-6 receptor. And this is done with another quite famous monoclonal antibodies that his name is tocilizumab. Siltaximab has been approved in Europe and US for the first line of IMCD, while tocilizumab is approved for first line treatment only in Japan. The approval of siltaximab for idiopathic multicentric Castleman disease derives from these registrative studies published in 2014. This is a double-blind, placebo-controlled study. It's a phase 2 randomized study. Enrolled IMCD patients, both naive and pretreated. Patients were randomly assigned with a ratio 2:1 to siltaximab, 11 milligram per kilo every 3 weeks, or a placebo. 79 patients were randomly assigned. Patient continued treatment until treatment failure. And the primary endpoint of the study was durable tumor and symptomatic response. As you can see from the Kaplan-Meier curves, to the left, you can see the curve of time to durable symptomatic response. Patients treated with siltaximab in blue have a very rapid time to durable symptomatic response, more than double. While on the right, you can see the time to next treatment. And again, the patients receiving siltaximab do significantly better than patients receiving placebo. But what is also very important is on the right, the table of adverse event. And as you can see, this table is almost blank. So there are very, very few adverse event of grade 3 or more, mainly fatigue, localized edema, night sweats, and so on. No infection disease. It is important to remind that siltuximab treatment might falsely increase the interleukin-6 concentrations. So because the complexes of siltuximab with interleukin-6 interfere with current immunological interleukin-6 quantification method. So the concentration of interleukin-6 should not be used to assess a response to treatment, while a good surrogate and simple biomarker for siltuximab activity is the C-reactive protein that goes down. Moreover, behind interleukin-6 inhibition, it is also possible to treat patients with anti-CD20 drugs, in particular siltuximab, in particular rituximab. Rituximab is an off-label for Castleman disease, as evidences of its efficacy derived only from retrospective studies, but could be used as a first-line alternative to anti-interleukin-6 in particular conditions, or as a salvage treatment. Here are presented some data from the ASH meeting of 2 years ago of a prospective register of Castleman disease patients, whose name is Accelerate, conducted by the Castleman Disease Collaborative Network. You can see in real life how the percentage of response in siltuximab treated patients are about 60%, and similar rates are registered in patients treated with tocilizumab, while the response rate of patients treated with rituximab is lower, about 10%, while siltuximab and tocilizumab demonstrate similar responses. This is again the epidemiological studies I showed you before. In this study, you can see that many Castleman disease patients are probably not treated appropriately and not following the published guidelines, as many patients receive corticosteroid monotherapy or no treatment. So I fear that probably these are not idiopathic multicentric Castleman disease. While from this report, only about 10% of patients received anti-interleukin-6 targeted therapy, and these were mainly patients, more sick patients, hospitalized patients, or patients with more minor criteria. Finally, the other important issue is that about half of patients do not respond to anti-interleukin-6 inhibitors, or do relapse after some months or years of efficacy. So what can we do? This is a real controversial issue. There are only limited published data from small retrospective series. For example, a combination of chemotherapy and immunomodulatory drugs can be used. For example, this TCP regimen, published 2 years ago by the Chinese group, is a regimen comprising prednisone, cyclophosphamide, and thalidomide. Or as increased mTOR activation was demonstrated in IMCD as a key pathway, some reports do suggest the usage of sirolimus, that is an mTOR inhibitor. And in this context, also a phase 2 prospective trial is ongoing. So we'll see the result in the next years. And another important drug can be the inhibition of JAK, of the JAK pathway. So ruxolitinib could be in the future a very interesting drug. Finally, this is we can go back to the first case that I presented at the beginning. The patient was diagnosed as with IMCD, non-severe form. He was treated with the siltuximab, and just after the first dose, he experienced a rapid improvement of systemic symptoms of laboratory parameters. while to see a response in the adenopathy, a complete response in the adenopathies, we had to wait 6 months after the treatment start. As we report, the patient is still receiving siltaximab every 3 weeks, and he maintained a good clinical response. While this is another recently treated patient, a female, 67 years old. She was admitted for a recurrent fever and vasculitic lesions on lower limbs. And when diagnosed, was diagnosed with multiple supra and subdiaphragmatic adenopathies detected by CT and PET scan. A lymph node surgical biopsy of the hepatic ileum lymph nodes demonstrated a follicular reactive lymphadenitis with interfollicular plasma cells and aspects of follicular regression. So this is again a typical HHV8, HIV negative Castleman disease, so idiopathic multicentric Castleman disease. What about, these are the 2 major criteria. What about the minor criteria? She has anemia, 9.8 of hemoglobin, normal platelets, normal albumin, elevated CRP and ESR, normal renal function, slight proteinuria. Most common viral infection were negative, interleukin-6 were negative. But as you can see on the right, she has both major criteria, 2 minor laboratory criteria, and 2 minor clinical criteria. All the other conditions were excluded, and so she was diagnosed with a diagnosis of IMCD. She was treated at the beginning, right after the surgical biopsy, with prednisone. She had an improvement in general condition, an improvement of vasculitis, but after steroids discontinuation, she had a relapse of inflammatory indices and vasculitis. And so we started treatment with siltaximab due to recurrent vasculitis, and actually she is doing well with resolution of vasculitis and a resolution of inflammatory indexes. These are my acknowledgements. The acknowledgements, of course, to all the networks that are working together to study and to treat Castleman disease. First of all, Castleman Disease Collaborative Network, International, the French Center for Castleman Disease, that is very active, and the Euro Castleman Disease Group that is recently funded in Europe, and in particular in Italy, our association, Amica Association of Castleman Disease Patients. And here are my acknowledgements to all my Castleman patients, for people who helped me with this presentation, to our association, and to David Feingemann, who is the leader of Castleman Disease Collaborative Network. And thank you for your attention. I'm pleased to receive your comments or questions.
Thank you very much, Dr. Ferrero, for your presentation. So, yes, I will give again the possibility to the audience to unmute themselves and take the floor, because now it's not possible. And I, of course, encourage the audience to intervene with comments or raise questions, so we can have a good debate. I can see one hand raised. I think you can unmute yourself, Professor Braun.
Hello. Okay. Thank you, Dr. Ferrero. I have 2 questions. The first one is, first, thank you for your summary. It was excellent. And how long do you treat, or when do you decide to stop the siltuximab? That's one question. And the other one is, do you have any experience with lenalidomide?
Yeah, okay. This is a very important question. There are no data on siltaximab discontinuation. So the indication is to continue siltaximab every 3 weeks until treatment fails. There are some data from the registrative studies. Some patients did not discontinue treatment with ciltacimab, but shifted from a every 3 weeks schedule to a every 6 weeks schedule, and actually did maintain the response. Interleukin-6 inhibition is not an etiological therapy. So it's a therapy that blocks the inflammatory response and theoretically does not cure Castleman disease. So this is the reason why a prolonged treatment is required. In my personal experience, I have a patient who discontinued ciltacimab, but only after 5 infusion, and had a rapid relapse of the disease. He was re-challenged with ciltacimab, and he responded again for years. So the personal opinion, and not also the personal opinion, also the guidelines suggest to continue the treatment until progression.
Okay, thank you.
The other question is about lenalidomide. There are some reports of activity of lenalidomide, but in my personal experience, I've never used it, also because it's an off-label. Actually, I use thalidomide in the TCP published regimen, but unfortunately with no response in one case.
Thank you.
Thank you.
One question we can ask to the audience could be if the audience is aware of the guidelines, both diagnostics guidelines and treatment guidelines that were published respectively in 2017 and 2018 by the Castleman Disease Collaborative Network, and and what are the opinion if they are used, these guidelines are used in the clinical practice or not. Also in different countries, because there could be regional differences in Europe.
Let's see if someone wants to answer. If not, I'm seeing 2 questions in the chat. Okay, so I can address the first question in the chat, then if someone from the audience would like to come back to your question, of course, the debate is always open and very welcome. So the first question is, in patients with POEMS MCD or POEMS or MCD with strict complete protein response, but adenopathies with persistent uptake in PET, do you consider it a treatment failure? How long do you expect it to go negative?
Yeah, okay, so this is a case of POEMS MCD, so it's not an idiopathic multicentric Castleman disease. I'm not aware of the treatment that these patients receive, the specific treatments, but if you have a POEMS, you have, as I said before, you have to treat the POEMS, so to treat the monoclonal component with proteasome inhibitors, with lenalidomide, with melphalan, or what else. So the main objective, okay, so this patient was treated with autologous transplantation and then lenalidomide. So the main goal for POEMS is to control the M protein, and especially to control the polyneuropathy and the endocrinopathy, so to control the symptoms of POEMS. It is not important to, it is not essential to induce a response in the adenopathies. And this is the same also for idiopathic multicentric Castleman disease. So the CR, the instrumental CR, the radiological CR, or the PET, complete metabolic response, is not the main goal of the treatment, because the main goal of the treatment is the symptomatic control of the disease. So in this specific case, I would not consider this partial response as a treatment failure. But if the M protein and the symptoms of POEMS are controlled, So I think it's a good treatment. It's a good treatment response.
Thank you very much. Another question I have received. I have a question about TAFRO syndrome. Do we see it always at the beginning of the diagnosis, or patients can have it after, like evolution of the Castleman disease? Thank you.
Yes, luckily we do not see TAFRO always at the beginning of the disease. Sometimes we can see TAFRO as a consequence of a clinically stable Castleman disease for some years, or as a complication of Castleman disease misdiagnosed or mistreated, for example, treated only with steroids, and then we can experience a relapse of Castleman disease with a very aggressive relapse of Castleman disease with a TAFRO syndrome. On the other side, sometimes we have to keep in mind what TAFRO syndrome is, because if we face a patient with a general rapid worsening of organ function with the characteristic of TAFRO, we have to diagnose it very rapidly, and to treat this patient with interleukin-6 inhibitors, first of all, very rapidly, because otherwise the risk of death is very high. So one of the problems of TAFRO syndrome is that is either not diagnosed before patient's death, or is diagnosed too late, and so treatment are not effective. So there are both.
Thank you. So maybe waiting if other questions or comments arrived, I can remind the next and last session of this program that will close the cycle of webinars on Castleman disease. So it will be in 2 weeks, the 8th of March, more than 2 weeks, 3 weeks indeed. And we will have 2 speakers, so Professor Mark Bulwer and Dr. David Boboul, and we are going to talk about Kaposi sarcoma, herpes virus associated multicentric Castleman disease, and HHV8 associated multicentric Castleman disease. So I'm seeing some comments in the chat saying that you had a great lecture, Dr. Ferrero. I received it on my private chat, so I echo the same. Thank you very much.
Thank you. Okay, I can remind that HHV8 Castleman disease is a similar disease to idiopathic. It's quite simple to diagnose it because HHV8 is positive, so the pathologist can help the clinician in the diagnosis. It is important to recognize HHV8 in different, in contrast to idiopathic Castleman disease, because the treatment is different. Main treatment, as you probably will listen in 2 weeks from today, the main treatment for the HHV8 is rituximab, so anti-CD20 therapy, while siltuximab interleukin-6 is not approved for this different disease.
Thank you very much. So, well, I would like to express again my gratitude for sharing with us your expertise, Dr. Ferrero. And also I would like to thank the audience for the debate and for being here. And so I will say, let's see in 3 weeks. Thank you very much. Have a nice afternoon.
Thank you. Thank you all.
Thank you. Bye-bye.